Antimicrobial resistance isn't a new problem. It's an ancient one. Bacteria have been producing antibiotics and evolving resistance to them for hundreds of millions of years. What's new is the speed at which resistance is spreading because of the scale at which we use antibiotics in medicine, in veterinary medicine, and in food production. This talk is about the mechanisms. Once you understand how bacteria resist antibiotics, you'll make better prescribing decisions, better culture and sensitivity decisions, and you'll understand why stewardship matters. These four mechanisms as four ways to beat any security system. You can neutralize the threat before it acts. That's enzymatic inactivation. You can change the locks so the key doesn't fit. That's target modification. You can install a bouncer that throws the intruder out as fast as it enters. That's the efflux pump. Or you can simply seal all the entry points. That's reduced permeability. Pseudomonas aeruginosa is particularly frightening because it can deploy all four simultaneously. Beta-lactamases and extended spectrum beta-lactamases in particular are the mechanisms driving the most resistance crises in gram-negatives globally right now. Because they're usually plasmid-borne, meaning they spread between different species. That should keep you up at night. Resistance genes don't stay in one species. Conjugation, plasmid transfer between bacteria, doesn't even require the bacteria to be related. A resistance plasmid from a salmonella in a chicken can transfer to a commensal E. coli in a farm worker's gut. That E. coli transfers it to a Klebsiella, and plasmids carrying multiple resistance genes, multi-drug resistance plasmids, mean a single horizontal transfer event can render a bacterium resistant to 8 or 10 classes of antibiotics simultaneously. This is why the antimicrobial resistance crisis is a One Health problem. Animal use, human use, and environmental reservoirs are all connected. A culture and sensitivity report is a powerful tool, but it's not infallible, and it requires interpretation. The MIC tells you how much drug it takes to stop growth in a test tube in ideal laboratory conditions at 37 degrees Celsius in a standard growth medium against planktonic bacteria. Your patient is not a test tube. An abscess has acidic pH, low oxygen, and sequestered pus, conditions that can dramatically reduce antibiotic activity. A biofilm infection can require concentrations 100 to 1,000 times higher than the listed MIC. A susceptible label on an isolate from ear canal discharge doesn't help you if you're prescribing a systemic drug that doesn't penetrate the external ear canal effectively. Use the culture sensitivity as a guide combined with pharmacokinetic and pharmacodynamic reasoning. Every antibiotic prescription a veterinarian writes is a public health decision, not just a clinical one. This is not an exaggeration. Fluoroquinolones and third-generation cephalosporins are on the WHO's list of critically important antimicrobials, drugs we absolutely must preserve for human use. They are also increasingly prescribed in veterinary medicine. When we use them routinely, we select for resistant organisms that can transfer resistance determinants to human pathogens. The VCPR, the veterinarian client-patient relationship, comes with responsibility. Culture before treating. Choose narrow spectrum. Avoid treating viral infections with antibiotics. Comply with label instructions or have a documented justification. These aren't bureaucratic hurdles. They're how we preserve the drugs that keep animals and people alive. Microbial resistance is the defining challenge of modern medicine, human and veterinarian. The four mechanisms we covered aren't just academic concepts. They're the reason some of your clinical cases won't respond to first-choice drugs. And they're the reason the drugs you're learning about today may not be available to your patients in 20 years if stewardship fails. The plasmid biology explains why this is a One Health problem. Resistance doesn't stay on the farm. The stewardship principles give you a framework for every prescription decision. Be the clinician who cultures first, chooses narrowly, and saves the big guns for when they're needed. It matters. Read the question, think about it, and we'll then work through it together. This question gets at mechanism versus dose. MRSP carries the MECA gene, which encodes an altered penicillin-binding protein, PBP2A. Beta-lactam antibiotics, including amoxicillin, work by binding to PBPs and inhibiting cell wall synthesis. PBP2A has such a low affinity for all beta-lactams that no achievable clinical dose of amoxicillin would saturate it enough to inhibit cell wall synthesis. This isn't a dose problem. It's a target problem. The target has been modified so the drug mechanistically cannot work. No dose will fix that. You need to switch to a drug class that targets a different mechanism based on culture and sensitivity results. Options might include chloramphenicol, clindamycin if susceptible, or in severe cases, linezolid. This is why mechanism knowledge guides prescribing. Read the question, think about it, we'll then work through it together. This is antimicrobial resistance in real time, and it has a straightforward explanation rooted in evolutionary biology. Every time an antibiotic is used, it creates selective pressure. Bacteria that happen to carry a resistance mechanism survive and reproduce. Susceptible bacteria die. The resistant survivors pass their genes vertically to daughter cells or horizontally to neighboring bacteria via plasmids. Repeat this across millions of animals and decades of use, and the proportion of resistant organisms in the population increases. Patterns that once worked, low-dose growth promotion use, routine metaphylaxis with the same drug every year, have inadvertently enriched the bacterial population for resistance. And because resistant genes cluster on mobile plasmids, resistance to one drug often co-selects for resistance to others. The bacteria haven't gotten smarter. Natural selection has done exactly what we should have expected. Read the question, think about it, we'll then work through it together. This is a stewardship question, and the answer is amoxicillin, assuming the clinical situation supports it. All three drugs show susceptibility, but they are not equivalent from a stewardship standpoint. Amoxicillin is a fluoroquinolone, a critically important antimicrobial that we need to preserve because of its importance in treating serious infections in humans and animals. Using it for a routine UTI caused by an amoxicillin susceptible organism is indefensible stewardship. You're burning a critically important antimicrobial for something a first-tier drug can handle. Trimethoprim sulfa is a reasonable alternative, but still broader than amoxicillin. The narrowest effective drug for a susceptible organism is always your first choice. Save fluoroquinolones for when you need them. Resistant organisms, infections in sites with poor drug penetration, or cases where narrower options have failed. Stewardship is making the boring, correct choice when the flashy option is available.